I just want to take a few minutes. It may not even take 5 minutes, but just want to kind of introduce myself. My name is Jeremy Harrell. I'm the founder and CEO of Veterans Club Incorporated, also the veteran co-chair for the Veterans Community Alliance of Louisville. Our organization works really, really hard every day in a multitude of ways to try to mitigate veteran suicide. And the way that we see it, based on our work at Veterans Club and me personally, is connection. We believe that connection is one of the most effective ways to reduce veteran suicide. When you look at the numbers and you look at people who take their own lives from suicide, you see that they usually don't do it when they're amongst others. And so our goal at Veterans Club is to create opportunities for veterans to be in community with one another at all times, whether we're having an event, whether we're doing it virtually, whether they use our social media platforms, the private groups that we have to stay connected. We've seen really, really good results by ensuring that there's always a connection piece there. There's always a way to connect with someone else, whether it's another veteran who has been through that or understands, or whether it's through their mental health providers. The VA, we work really close to the VA, both VAs in the state of Kentucky, to be a supportive function for what the initiatives that they have. And I think we could all agree when we look at a summit we just completed, the Peers and Partner Summit, we talk about the importance of peer support as well as clinical support. And we believe at Veterans Club, and I believe personally from my own experience, overcoming thoughts of suicide and struggling with mental health due to my service in Iraq, I recognize that collectively it's the best treatment, it's the best way to go, right? Both clinical, peer support, and for me, even faith-based opportunities as well. And you put all those things together, and then there's a bunch of tools in the toolbox that veterans can use and can rely on in a moment where they feel the most vulnerable. They have several options at their disposal on how they can overcome the thoughts of taking their own lives. And we believe to continue that effort, to continue to partner with organizations such as NAMI and VA and just anybody who's out there who is in this fight with us, to continue to come up with creative ways of making sure that we're doing the most good for those who are in this space to where they want to end their lives. It's been really challenging as of late due to the issues that we're seeing in Afghanistan. And then right after that, we have the 20th anniversary of 9/11. So we've had about 12 calls in the last couple weeks of veterans who were thinking about taking their own lives. Even got a personal picture sent to me from a veteran who had a firearm in their mouth and had to kind of mitigate that situation. So it's important that we have this conversation. I love everybody that's on this panel and everybody joining us who's interested in learning. It's all of our responsibilities, right? It's not just those who run organizations that do this. It's everybody's responsibility to take care of one another and ensure that we're supportive in that way. So as of right now, that's really my message, is the connection piece is the foundation, along with the other modalities that I discussed. But looking forward to hearing everybody else's feedback as well.
Thank you, Jeremy. That was informative and unfortunate both, and that's why we're here today. Kelly, you are next on my list. Do you have anything you want to share on the screen? You have the ability to share.
Not at the moment. I have some resources at the end in the form of some PowerPoint slides I'd like to share with folks, if that's okay, if we have time for that.
We definitely do.
Okay, I do have some statistics in front of me that I won't put up on the screen, but so every year the VA does I guess it's every 2 years the VA does research, and then they publish a national suicide data report for veterans. And so we just in early September got the results from the most recent data, which the way that suicide data amongst the veterans is collected, it's about a 2-year lag. So we get the most updated information just from 2019, just because of like coroner reports, the way that it's all gathered in, and the way that it's presented. So This is really new to me, so I don't have it just in my head to be able to kind of just knock it out like I could from last year's data. So I guess I should introduce myself first. I'm Kelly Markham. I'm the Community Engagement and Partnerships Coordinator at the VA Medical Center in Louisville. Like Jeremy said, I have a couple of counterparts in Lexington as well. And we are tasked with what Jeremy was talking about, the VA's kind of new focus on community-based intervention. So for years and years and years, the VA has always been really clinically focused, and, we're like the largest public healthcare system in the world. So, we look at it as we want to be like this all-encompassing one-stop shop for everything. And that works great for those veterans who are involved in VA healthcare, but we also know that greater than 50% of veterans are not involved in VA healthcare for whatever reason. So we are really focusing on taking those clinical interventions that we know are working and starting to push that out into the community. So, support organizations like Jeremy's and others who may not have like an overall focus in suicide prevention, and giving them some strategies to be able to, work with their veterans so they are as effective as we are in some of the things that we're doing. And just a few, like I said, a few data things from the most updated report. So in 2019, the veteran suicide rate was 31.6% per 100,000, or 31.6 per 100,000, which was almost twice as high as the rate amongst the general population, which was 16.8 per 100,000. So veterans continue to be very overrepresented in suicide data, unfortunately. An anchor of hope or a positive thing with that is that in 2017, that rate was much higher. So the U.S. veteran population was about 66.3%. The rate difference between veteran and non-veteran, and that data from 2019 was about 52% greater risk. So we are bringing that risk down among the veteran population, while the general population continues to rise. And in Kentucky, I heard a statistic there earlier that, was kind of shocking as well. So we just continue to have, troubling rates of suicide in the general population as well. From 2017 to 2018, the adjusted rates fell among veterans with recent DHA care. So for the first time since they started doing these reports, the suicide rates among veterans that were involved in VA healthcare went down a little bit, whereas the population of veterans that was continued to go up at about a 2.5% rate. And from 2018 to 2019, there was a 7.2% overall decrease in the age and sex adjusted veteran suicide mortality rate, while among non-veteran U.S. adults, that rate fell by 1.8%. So some of the things that we're doing, we're starting to turn those things around with our clinical interventions. So, in case management, carrying contacts, safety planning, lethal means safety counseling, all these things are really effective and helpful, and all the support we're able to provide folks who are involved in healthcare. But, we need to focus on those folks that are not necessarily getting that message, not getting all those tools like Jeremy was talking about to put in their toolkit far upstream from when they are feeling acutely suicidal. So, suicide is not very preventable whenever that person is alone, has a firearm, and is feeling, that sense of burdensomeness and not having that community. So we need to be able to put those tools in there early on, provide them with safety planning, set up something for whenever they are having struggles with their, kind of acute distress, to help them limit their access to that means that could potentially be, very lethal for them. But I think we had to change the conversation about how we're doing that too. And I'll talk a little bit about that too as well. But and it's because of this data point, firearms were more often involved in veteran suicides in 2019 than 2018. Among veteran men who died from suicide, almost 70% were firearm related. It was a little bit lower than that in 2018, but it's always been the trend line, where firearms have been the most lethal by far amongst the veteran population. And that's true of male and female. So even though in the general population, it's like around high 20s, low 30%. In the population, it was almost 50% in 2019. So female veterans have that, the same access to, comfortability with firearms. They get those same messages about, kind of the dehumanization of not only the enemy, but when we dehumanize the enemy, we dehumanize ourselves. So we start to develop what Thomas Joyner called that kind of acquired capability to get past that fear of death and actually attempt to kill ourselves. So I think that's, again, why we're looking at veterans at being a very vulnerable population. So like I said, we want to focus now on clinically plus community-based interventions. So what I'm doing and what Haley and Ann are doing in Lexington, and we're doing all over the country right now, is like I said, we're trying to find these little coalitions of these little groups of people who are working really hard to prevent veteran suicide, and trying to kind of band everyone together, try to find out what is working in these communities that we are not aware of. So, things that work in rural LaRue County may be different than what works in Jefferson County or downtown Louisville. So we want to find out like what is working in those communities and how we can support that, and how we can also bring that back to the veterans we serve from those communities. So we're trying to partner with faith-based organizations and grassroots veteran support organizations and all this stuff, and just trying to develop like an overall, like I said before, kind of the meeting started, like a village of veteran suicide prevention or suicide prevention overall in the state. We want to be able to work together and just really quickly be able to say, hey, I know who can help you with that, or, I know what I can do to get you to the next level of care if you're feeling like this, and that kind of thing, and provide the most evidence-based practices too. So, everything that we do is evidence-based. Everything that's all of the stuff that came out of the national data report and all the 3 focus areas that we're trying to focus on. So they narrowed those down based on the fact that you can actually empirically test some of the stuff and find out that, the symptom burdensomeness is extremely common in the veteran population. And it's also very common in the population of those who attempt suicide and who die by suicide. So, we can test that, and we know that that's, even though it's really difficult to narrow down who might be at elevated risk, we can do that to some degree based on those things. Let's see. So I just based on the information that I got about what you kind of wanted to have discussed on this, I saw there was one of the questions was the why of suicide risk. And, this is one of the most difficult things. It's just, there's no single cause of suicide. There are triggers, there are, events that cause folks to, get past that point of tolerance whenever they're dealing with whatever they're dealing with that gets them to the point where they're feeling suicidal and might act on it. But generally that's because there are lots of underlying things. So a lot of those can be, anything from factors that are kind of long-term, and they're just kind of, those things that are, I'm not sure what the word I'm looking for here, but those things that are just kind of like endemic to who you are. So me, male, veteran, 45 years old, that's pretty high risk population right now, depending on kind of a lot of other things like employment, some of your diagnoses that you're being treated for, substance use disorders, things like that. All those things are risk factors. It's on societal levels too. So dealing with the COVID pandemic, dealing with the isolation that goes along with that, and lots of other things that are societally motivated, unrest, things like that can all cause distress that can push folks towards suicidal thinking. So what we're really looking at doing is trying to raise up those protective factors that we all know that we have and veterans have, and trying to focus on those while trying to mitigate those risk factors. And I think the thing that I heard that when I started out in this 6 years ago in suicide prevention that was most helpful for me was the writings and the research of Thomas Joyner. I really thought that, when I heard that, that really made me think suicide is preventable. because I kind of came into it as a veteran coming from a social work, a different type of social work job, and thinking, I don't know if I want to get into this or not. This is just going to be like, a lot of heartache over and over again. But hearing, him be able to actually do this research and find these little empirical data points that show if we do these things, we can prevent suicide, then that really gave me like empowerment that, hey, I do have tools to be able to do that. So he talks about the interpersonal theory of suicide. And if simultaneously have these three components together, that's when you're super at risk. So like Jeremy was talking about, that sense of thwarted belongingness, like not having a tribe or not having, a group that you feel like you are a part of. And that can be your family at a micro level, all the way up to society at a macro level. Veterans, especially coming out of the military, they have that community. And when you come out of the military, you not only are like ending your job, but you're ending your, identity to some degree. No longer am I Sergeant Markham. I'm, now just whoever civilian. So, there's a lot of loss of more than just a job there. There could be a loss of, financial and healthcare support and all those things. But that sense of thwarted belongingness is really important too. So, I do agree that we really need to promote connectedness in our veteran community to pull people out of the shadows and out of that isolation. The second thing was perceived burdensomeness, which he found to be the most reliable indicator. Like, you have that feeling that you are, quote unquote, better off or more valuable to the people that you love, dead than alive. And a lot of that's situational. Like if you have, if you have an incarceration situation or if you have an illness of some kind, but some people just have that general feeling of, I'm just causing more distress to the people that I love or am beholden to than I'm, than the good that I might be providing them. And the overwhelming majority of the time, that's a false narrative. If you ask the people that they're concerned about, those people would say, no. Oh, okay. So I will, I think that's a good place to stop. So I don't run over time anymore, but hopefully we'll have time for questions later.
We definitely will. And we have Eddie Reynolds next. Eddie, I'll let you introduce yourself and say why you are here.
Well, Rhonda, Nancy, I want to thank you all for this opportunity. This is just a great, not only a great, but a very timely topic. Rhonda and I had been talking about this, and then I checked my phone one morning and find that this past year has been a record year for suicide, violence of all types, definitely in Kentucky and across the nation. And we are also aware that brain injury is a factor. You've heard Kelly and Jeremy both mention that veterans, their rate of suicide is double that of the non-military. But brain injury does cause people to want to commit suicide. WebMD said that even 7 years after a TBI, that many survivors have a 75% higher risk of suicide. That whether it is acquired through service overseas in the military or whether it's acquired here due to an accident or a fall, it does aggravate brain injury does aggravate a lot of the leading factors of suicide, changes in physical health or mental health, depressed mood, and there's significant loss. A lot of people have lost their identity through the loss of their job, their ability to do a high profile, a job that acquires that has a lot of status with it. So whether it be through, as Jeremy and Kelly both just did a great job remarking, the loss of support, whether it's military or not, people need that source of support and connection. Changes in family roles where caregivers They have to become care receivers. So things happen a lot on that. So I am glad that BIAK can be involved. We primarily put the three aspects of my mission. I'm the program director, and my job is to make sure everybody that has a brain injury can find the information, the resources, and support that they need. And we realize that these things do help, but we've also been able to work as far as resources with Jeremy and Kelly through our veterans online group, which has kind of evolved to be more of a resource group for people that work with veterans. A lot of times, it helps somebody who works with veterans to know that as good as the VA is, that there are other resources, there are other avenues that a person can also achieve, who's out there working, what's not. But we also have our support groups. So we're glad to know that these are a part. Of course, the job, I think Kelly did a great job. It's reaching the people who are separated, who don't feel that connection to other people. But our job, we keep plugging away, providing patient information, resource to be a source of resources and connection to support groups. Thank you.
Thank you, Eddie. And next we have Nancy Brooks, my executive director. Nancy, tell us why you're here and how you help with risk and prevention.
Yes, well, I am the executive director for NAMI Louisville, and we, being the local affiliate of the National Alliance on Mental Illness, have always had the interest in supporting individuals who may be having thoughts of suicide. But one of the things that I wanted to share with everyone is that Louisville actually ranks poorly in almost every age group and every demographic when it comes to having higher than normal average of suicide each year. So that's something that really brought me closer to the Louisville Health Advisory Board's Behavioral Health Committee, because their work is circled around reducing that risk of individuals in our community who die by suicide and trying to change that outcome. So obviously, changing that outcome means we need to know more about who is at risk. One of the things we found is that in our community of Jefferson County and the surrounding areas, white adult males who live in the southeast or southwest part of the community tend to be our highest risk group. We've seen an increase in folks practicing law being at a risk, the elderly because of the isolation of COVID, and young people. So while statistics come slowly, as someone mentioned earlier, our state is really working to bring those statistics to us quicker than a 2-year period. So that's going to be really helpful in the future so that we can kind of dynamically look at what it is that's happening. Why are these folks at risk, and help prevent, if at all possible, the loss of life. Folks may know that suicide is the 10th leading cause of death for all folks in the U.S., but it is the second leading cause of death by youth ages 12 to 24. Suicide attempts among young people in that same age group have increased over 50% in the last year. So we're really looking at a very serious situation of suicide in our community. And one of the things that we're doing along with the Louisville Health Advisory Board in order to educate folks, give them some training, is to provide QPR suicide prevention training. That stands for Question, Persuade, Refer. And I'll give a little bit more information about that towards the end and show a graphic, but I wanted to mention it more than once. This training is free. It takes 1 hour to complete, maybe a little bit more depending on the speed of the instructor, and it's simple to sign up online. It's being taught virtually and in person if someone would want to do that, but primarily virtually. And we're willing to help support individuals who might have some inability to get onto a virtual training. So that training is really going to educate our community to be asking the right questions, to be looking for the right situations where they might want to intervene. What typically happens with the young people is that there's a big gap in the years between their onset of their symptoms and their proper diagnosis. And so what will happen in that age group is often they start self-medicating or using substances. They might drop out of school or get in trouble with the law, all things that put them at a higher risk for thinking suicidal thoughts and believing that their life is not worth saving. So what we really want to do is look for signs and symptoms. We want to look for, is the person talking about dying or hurting themselves? Do they show signs of hopelessness and having no reason to live? Do they think they're a burden to others? Do they talk about being in unbearable pain or feeling trapped? Do they sleep too much, too little? Are they impulsive? Are they withdrawn? Showing rage or seeking revenge, displaying extreme mood swings. These are all just things, the use of drug and alcohol, that could be something you would want to look for. So those people who are having those sorts of behaviors and conversations are actually more at risk, perhaps, than someone who's not having those signs. One thing that the Louisville Health Advisory Board found when comparing to other cities and doing research on what are some of the things that might happen is that often people will give away not just their prized possessions, but their pets. So is someone, in your neighborhood asking you if you can take their pet for them, that could be a sign. And we need to look not just in our immediate circle, but with our workplaces and with our friends and in our neighborhoods to be able to support these individuals. So how do we help? We listen non-judgmentally. That's very important. You're not going to debate, is suicide right? You're not going to argue or threaten. If there's more than one person in the situation, then talk one at a time so that the person who is struggling and trying to share their feelings doesn't feel overwhelmed. And keep that pace. Don't walk around. Stay calm. Keep your tone calm. And then you don't want something to snowball. So of course, whenever you know that something is going on in your life, or someone is expressing that they may have some of these thoughts of suicide, you need to pull weapons out of the house if there are guns or medications in which the person could use to die by suicide. You don't want to leave them alone. If they're a youth or someone who has a counselor, you want to get them back into their healthcare professional. And there's always the 1-800 number where they can call 1-800-273-8255 if there's any serious threats of suicide. NAMI Louisville is always here to support you as well. If you ever wanted to just, field the conversation with us, we can help you. We have helped some folks figure out how to get their friends to the hospital in a very safe way. For example, it's best to have 2 people in the vehicle. That way the individual won't try to jump or run. It's best to call ahead and let the hospital know that you're coming and that this person is threatening suicide. So there's just some things we can help folks with if they need that sort of help. Now, again, I wanted to mention QPR. The goals in the question, persuade, refer training are that you are going to learn how to ask the right questions. You're not going to give someone thoughts of suicide just by talking to them. You're going to learn how to persuade them to get the help that they need. And you're going to learn how to refer them to the best resources in your community. So what does this do? This makes you a leader in helping individuals survive the risk of suicide. It makes you a leader in mental health in our community, and all for 1 hour of free training that is occurring on many different days of the week and many different times of the day. So you're not going to be limited to when you can fit this into your schedule. I guess at this point, I definitely want to share that slide. And I think I can do that on this screen. Does that show, Rhonda?
It does not for me yet, but if it shows for everyone else, then they should be able to see it.
And basically what the slide shows is, if you cannot see it, it is telling you to go to namilouisville.org/QPR to sign up for the suicide prevention training. They're free through the end of November. They're very small fees after November, but we would really like to make sure that people jump on this opportunity, and especially during Suicide Prevention Month, which we are still wrapping up here, in order to be able to really join us in the fight to save lives. There's no one who would ever say, I wish I hadn't done anything. You're always going to wish you would have taken one more step or tried one more opportunity to save the life of the individual in your circle who died by suicide. So please, if you can see this information, great. If not, I'll say it one more time, NAMILouisville.org, and you go onto that website, QPR suicide prevention links at the very top. All you have to do is hit it. You can look at all the available dates and register. It's simple as can be. So again, guys, thank you so much for listening to my spiel and for having this opportunity to share with our community this wonderful offering.
Thank you, Nancy. Next, we have a person who is not on the schedule, but since we are down one person, Mr. John Broadus could not join us today from 7 counties in Newburgh Strong, unfortunately, due to a loss in his family recently. But Joe has graciously agreed to speak. So I will let Joe introduce himself and tell us why he's here and how he helps the community decrease those risk factors and help with prevention.
Thank you, Rhonda, and thank you, Nancy. I apologize for getting on late. I had a little technology glitches. So I came right in the middle of Kelly's informative information, so thank you, but I missed some of the other speakers. But I'll just take a couple minutes to tell you a little bit about Louisville Health Advisory Board. Nancy referenced it a little bit. I co-chair the Behavioral Health Work Group with Erica Limberger, who's a professor in the nursing program at Spalding University. And I've been involved in this work in suicide prevention in Louisville since 2015. I'm trained as a psychologist who's worked in the pediatric population for 30 years. And so one of the data points that Nancy shared with us was that it's the second leading cause of death of youth in our community nationwide. And so as a psychologist, I'm also very much into numbers and how do we use data to drive our decision making. And so I don't know if this information was shared, but I want to share with you 2 points that I think is really relevant to the conversation today and what we're trying to do with the Louisville Health Advisory Board, the Behavioral Health Work Group, to deal with suicide prevention. So the first one is, probably many people in the audience today are from Kentucky. So just to let you know, nationally, a data point there is if you filled up the Yump Center in Louisville and the Rupp Arena in Lexington, that's how many people die each year by suicide, about 47 to 48,000 people. More locally in the state of Kentucky, when you went to bed last night, today, this morning, at least one of our friends, colleagues, or loved ones died by suicide. A Kentuckian dies by suicide every 11 to 12 hours. So that just gives you a little bit of how important it is that the work that we do with this. One of the things that I'm proud about the Louisville Health Advisory Board, we are data driven. And so Nancy shared some data, and I'm sure some of the other speakers this afternoon or this morning about what groups in the community are struggling more with suicide. And so what we're trying to do with the Louisville Health Advisory Board is to take that data in real time and look at that data and what can we do differently, right, to do suicide prevention. And so Nancy referenced this a little bit already, but Recently, in a little less than a year ago, we got a grant to do suicide prevention, multiple pieces here in Louisville. And we're working with the state, and NAMI's a backbone program. They're our project manager. We're very fortunate to have NAMI on board with us. But Nancy talked a little bit about doing QPR training, and that's for the general public. And so we are looking at our data and to look to see what communities do we need to put a more of an emphasis on trying to get into those communities. So we are providing trainings throughout the week. This is Suicide Prevention Month, but we'll be going into October. We're trying to make it as easy as possible for people to sign up for the general public. We have mornings, afternoons, evenings, weekends. We'll also do for large organizations. If you want to set something up, we'll be happy to do a training. But what was important when we looked at our data is we had to diversify our bench of people who can provide that QPR training. That we wanted to reflect, our trainers reflect the communities that they live, work, and play in. And so another piece of this is that we provided at least two train-the-trainer models programs for QPR. So we really expanded our bench for trainers. And so I'm really excited about that piece, that we're looking in all parts of our community, trying to reach into each community, part of our community, to provide the services of the QPR. So we're trying to reach the general public because we're all friends, loved ones, or colleagues of people who might be suicidal. And how do you ask that difficult question? So in the QPR training, as Nancy referenced a little earlier, we actually teach people to ask that question, develop that relationship, provide that support, and then refer that person out to a professional in the community who does this work full time. It's really based on the same premise as CPR. If any of you folks have ever taken training, that with CPR, you recognize somebody who's in distress, cardiac arrest maybe, you provide support to them until EMS comes or the person's brought to the hospital, based on the same premise there. So we're working with our community, people in our communities. Then the second piece that I'm excited about is we are working with our providers in that we're doing trainings just for those folks too. And we have two trainings for clinicians. One is called AMSAR and one is called CAMS. And what that does, it provides tools that clinicians can use if they suspect that one of their clients or patients is suicidal, and then how to support them through treatment. So I think with LHAB, with our work group's mission of suicide prevention, I think we're doing the best of both worlds. We're focusing on both folks. The general public, giving them some training so they can give hope and support to people in crisis, and then also supporting those people who do this work professionally. So that's been our goal for Louisville Health Advisory Board. I've been involved since 2015. So I appreciate the opportunity to share a little bit about what we're doing. And I look forward to continuing the work that in this space, and then also the conversation that may ensue from this presentation today. Thank you.
Thank you, Joe. That was awesome. We do have Khalil Kennedy with us, but he is unable to speak on his behalf at the moment because he's listening from work, but he has sent in something that he'd like me to read. And this is on his behalf. So imagine Khalil saying this. It says, I feel like community is important, reminding people that they aren't alone and creating safe spaces to talk about their struggles. As a member of the local culinary scene, where long hours, grueling work conditions, and scarce opportunities for family or self-care are the accepted norm, I see it all the time. People are typically afraid to share when they're struggling. I'm here to listen and learn, but my personal hope is to inspire more people in my industry, restaurateurs, owners, and professional chefs, etc., to open up and normalize open dialogue with their staff, to make resources more known and accessible, and to make the service industry community a safe, healthy one for people to be a part of. And he is apologizing that he is in the middle of making some barbecue at the moment. That sounds delicious, but we thank you, Khalil, for that message, because it's important to remember that everyone from every background and in our community has their own struggles, and everyone is equally important as everyone else, and especially those who are in our service industry and business owners and those who have struggled to maintain jobs this year as well. That is a very important message. Thank you, Khalil. Anyone have any questions?
I was going to take a moment to kind of play off that. NAMI has a stigma-free workplace initiative, and Khalil's actually familiar with this. The whole purpose is to get those types of dialogues happening in the workplace to protect the individuals whom they themselves or their family member needs to seek professional mental health care, but feels intimidated or resistant to asking HR or their boss about those sorts of resources. So we become the liaison for them. They can work, we work to build the culture in their environment while they still have a safe place that they can ask these questions. And after years of partnership, our goal is that all workplaces are more like the one Khalil described, where you're supporting each other and talking to each other and giving every individual on your staff the ability to speak freely about their mental well-being as freely as you would speak about your physical well-being and the needs that you might have in that regard. So anyone wanting more information on that can reach out to NAMI Louisville.
We just lost Khalil. I forgot to mention before he left that he is the owner of Four Pegs, which is an awesome restaurant. And like Nancy said, he has been one of our StigmaFree partners. Oh, Khalil's back. Welcome back. I was just saying who you are, Khalil. I forgot to mention who you were in your speech. Anyone have any questions for any of the speakers here today? Or you can talk amongst yourselves about anything that you think that we need as a community to change, or how we could come together as a community to make this change happen.
I just want to say that I think, you know, we should have more conversations like these, and I love bringing different agencies, different organizations together to kind of collaborate and talk about strategy and initiatives that we have in order to create a better environment and to mitigate some of the suicides, whether veteran or non-veteran, that we're seeing in our state, in our communities. And I just, you know, I'm hopeful that we do more of these and we have more panel conversations and get the community involved, the public involved, and get them really tied in to hear what we all have to say as we do this work every day, because oftentimes we're not able to display what we do in order to prevent these things. And I think it's equally important that the public sees the process and sees all the behind the scenes effort and research and studies that go into this, so they know how serious we are in regards to you know, mitigating the issue. And I really enjoy these kind of conversations and hearing from all the people on the panel from different places and different, you know, strategies and things like that. So I appreciate these conversations.
One of the things I sometimes say, Jeremy, that you brought into my mind is that mental health is a serious concern for our community. It is at the root of many other dysfunctions, such as substance abuse and homelessness and all these things that we're trying to wrap ourselves around as a community and try to solve. I think we could all put our jackhammers and our you know, lawyer gavels down for probably 10 years and focus on mental health and still not truly turn the corner. So for those of us who are working in this industry, we have to work nonstop. We have to think constantly about how we can improve what we're doing, how we can reach a better audience, and how we can support the individuals who are open to support. And I think many times it is about communicating. It is just about where you started earlier, Jeremy, communicating, keeping those lines open, letting people know that you're a safe place. There was a early leader of NAMI, whose son eventually lost his battle with schizophrenia and died by suicide. And his story was encapsulated in a play he had written before his death. One of the most telling factors in that play is when he's in Central State on a forced period of time, and he says that there's an orderly, that he doesn't even remember his name. But every day that person gives him hope by giving him humanity, by smiling at him, by asking him how he's doing, by being a real individual. And that is something that all of us can do. You do not have to be a mental health care professional to be kind to someone who's hurting. So, okay, I'm off my soapbox.
No, that's good. And before I forget, Kelly's on here, and I've known Kelly for a while, and we work very closely with both VAs and the initiative to have community engagement. Folks from the VA come out and engage with organizations like mine and others. That's going to be a game changer in our fight against veteran suicide for sure. I appreciate it as not only a leader of an organization that works hard every day to try to work through these mental health challenges that veterans face, but I'm a veteran who has mental health challenges of my own from my service in Iraq. I seek care at the VA. I'm proud to say that, and they've come a long way in a short period of time with recognizing that, hey, maybe we need to step outside the box here. Maybe we need to connect with community partners so that we can collectively do the most good for veterans that we serve. And I'm really excited about that. I've been a part of whole health steering committees and things like that. And I just, kudos to the VA for hearing veterans, listening to veterans, and allowing their employees to come out and their mental health providers to come out and actually get involved in the community and see boots on ground, kind of what's happening. So I just want to kind of, give that shout out to Kelly. I know that he works really hard. He's perfect for this position. And I always like working with him, and there's some other folks in Lexington too. So I'm looking forward to seeing what it looks like in the next couple of years as this develops. And I believe that we'll see a reduction in veteran suicide. At the very least, we'll see more programming that will, help eliminate as much as we can in that way. So I just wanted to share that comment since he was on here with it.
And Kelly, you said that you might have some slides that you wanted to show toward the end. Did you want to share those still, or?
Yeah, I put a couple of links in the chat for things that I thought might be helpful to have, but I'll go through and try to share just a few things that I usually, whenever I do a presentation, offer folks, because I'm not clear on who the audience is. I know we've got some clinical folks and some veteran service organizations, and I'm not sure about who the rest of the audience
is. Everyone.
Yeah, so I thought if it's going to be on Facebook, you might, just get individuals who, may be struggling, and also individuals who may have a person in their life that is struggling or they're concerned about too. So some of this will be helpful to one group and some to others. But I did want to also just kind of stamp home what Nancy was talking about with just being able to provide some humanity with folks. And that was something in doing AMSR training now is really something that we are focusing on with that, is like understanding what it's like to feel, suicide is the option for you, and understanding where that comes from that kind of, being in a clinical setting and being kind of forced to be there sometimes, being scared about it, being concerned that your needs are not getting addressed. And this was like your last hope was to come in for care and ask for care and help. And then you don't get that feeling of hope. And then whenever you're released, that's why people are much more, at risk for suicide in the days and the days and a month or so right after discharge. So I think that's something that we really should focus on as well, is just kind of being there and being empathetic for folks, and not get in that situation where we're just kind of like trying to meet deadlines and get all the X's or all the boxes checked and everything whenever we're working with someone. And so let me figure out how to share screen here. You guys see that? the save training slide. It's showing up.
Yeah, I see it.
Okay. So SAVE is something similar to QPR. It's kind of based on the same principles and components, but it's specific to military and veterans. So there's a few things in there that are, kind of more specific to the veteran population and some of the ways that they might present with suicidality and some of the options for care, that kind of thing. And so it's about a 25-minute video that you can, I put the link in the chat, go to YouTube and watch it. And it's really kind of more than anything, what it does is it empowers us to feel comfortable in having those conversations because, I think that's what prevented me, even as a clinician, doing trauma-focused therapy before I got into suicide prevention was kind of like being a little concerned about if I ask this question and get a positive response, what do I do from there? So this really, I think, empowers everybody, from clinicians to civilians, individuals who are concerned about, someone in their life. It could be a little helpful tool for you to have. The crisis line, obviously, is the National Suicide Prevention Lifeline until you press 1, and then it becomes a Veterans Crisis Line. And there are also text and chat options. We know that, today's my birthday. I'm 45 today. But I'm 45, so I'm even still more likely to like text and chat with someone. I just don't like talking on the phone. So if I'm feeling vulnerable and I'm kind of like ambivalent or wary about trying to talk to somebody about what's going on with me, I may be more likely to like have that extra wall of anonymity at first and start to send a text or a chat and say, hey, I'm just wanted to kind of feel this out and see what help I might be able to get. So those are really valuable. And I think things that we don't promote as much as the call line. But I think that's something that everybody should know about as well. And some of this stuff is, like I said, there are warm lines if you just have someone who just needs to talk to someone and it's not a crisis. And I can give these slides to someone who can, put them out on Facebook or something later on if you'd like. Just some Kentucky specific mental health resources. The Be There campaign, you just go to the BeThereForVeterans.com. Again, it gives you just some information about how to support veterans and how to support a veteran that you feel like might be struggling with suicidality. Some social media posts that you can put up and things like that. Make the Connection is a resource where you can share from peers, like these are stories from peers that are in recovery from just about any sort of concern, mental health, substance use concerns, anything like that, that veterans might have. And you can search based on like keywords about things that you're struggling with or somebody is struggling with, and you'll be able to pull up like a group of these videos where someone will talk about their experience in their recovery, which is really helpful in normalizing things for folks, I think. Coaching into Care is a good call center where you can call in and just kind of ask questions about if you're struggling with getting someone into mental health care. So if you got someone who's ambivalent, you can always say, call this line and say, hey, I'm having trouble with someone. Can you give me some tips about maybe how to get them to be more agreeable to go and looking into getting some mental health care? That's just the crisis line. And we have a community provider toolkit if you happen to be that community provider who's interested in outreaching to veterans a little more specifically than you already are. And then for clinicians, the Rocky Mountain MIREC, which is the Mental Illness Research and Education Consortium or something like that. Basically, they are the VA suicide prevention and management experts. And so you can send an email to them with questions about someone you're in treatment with or in care with and get some feedback from them on anything from, risk assessment to safety planning, lethal means, and all that good stuff. So that was really all I wanted to share. Also wanted to kind of reiterate that the first thing I put in the chat as far as a resource was that lethal means safety link that will take you to a video and lots of resources about how to promote lethal means safety, especially with firearms in the veteran population. I mean, it's just hard to kind of underreport how much I think that will help with bringing down suicide rates among veterans. And we just haven't done a great job with doing that or messaging, not just in the VA, but just in mental health, period, because we live in Kentucky or the surrounding areas. Most of our population around here is rural, and and a lot. And we're talking about veterans, like we have a specific and special relationship with firearms, and there are a lot of folks around this area that do. And when you start having those conversations about limiting access, that's a non-starter for most of us. We're like, that we don't even hear anything you said after that, especially with kind of misleading information about, what's going to happen if I report something, or so it's a good place to get information about all that stuff and be able to have conversation with veterans in particular about, we want the same thing that you do. You want to own your weapons and you want to have, access to your firearms. You don't want to die, but sometimes you feel like you might kill yourself with those firearms when you're really distressed. We don't want to take away your weapons. We want you to live. We don't want you to die either. Here's how you can do that in times when you're distressed. Not all the time, but when you're in that acute to subacute time frame, when you're feeling really distressed and you feel like you might do something irrational or impulsive, that's the kind of thing that we want to help you with, to set up a strategy to do that. So I think that's where we just need to kind of change that messaging, and really have those conversations and not be afraid to have those conversations with veterans and other people that have a relationship with firearms. So. I will send slides to Jeremy, whoever else is interested. Okay. Thank you.
We would love to share those slides on our social medias. So I appreciate you sending those to us. If you reply to the invite I sent you earlier, everyone will get them. And then Khalil would like a copy of them as well, and I have his email, so we can provide those to him. Anyone else have anything valuable that they think everyone needs to hear before we leave?
I'm going to try this one on. For centuries, we've been addressing physical health. We've been making improvements in how we take care of ourselves and learning independently and through our medical practitioners how to better be physically healthy. But as a culture, we really don't look at our mental health that same way. And we've tried to make it a problem about the other. There are those folks over there who have this problem. But the folks on this panel today all know that's not true. And there's not one of us in the entire world probably who doesn't have a physical wound, a little scar somewhere that they can look at and go, oh yeah, that's when I tripped down the steps, or, grated against the fence, or was shot, or whatever the scar is from. We also have psychological wounds. They're from similar experiences, traumas in our life, the bullying in elementary school, whatever it might be, but they're there. And we don't see them, so we ignore them. And that is something I want our culture to stop doing, because physical and mental health are tied together. We will never be our very best until we address our own mental health and our own needs and look at those wounds and heal them and stop fighting against ourselves and all the things that we do as we go through our daily life trying to be the best we can be, but yet not really learning how to address our mental well-being. I would say that's where I'd like to see the future go.
Perfectly said, Nancy. Eddie, do you have anything from the brain injuries perspective on what you'd like people to know?
Well, actually, y'all have said it all very well. We want people to know that, as has been said, that no one is alone. There are people who are out there and who care, and there are resources. So, we're always glad to do our part, but as also has been said, we want to make sure we do everything non-judgmentally, because people are hurting, and the last thing you need to do is to make somebody feel guilty for hurting. So we want to affirm them and to let them know that they're important to us.
Thank you, Eddie. That is well said. Joe, I have a question for you as a mental health professional. How can someone feel more comfortable reaching out to find therapy or to find the right therapist for these situations?
Yeah, great point, Rhonda. Thanks for asking the question. Really, the question is, who do you feel comfortable with, right? Because so often we're not going to go in the yellow pages and look up therapists or psychologists or psychiatrists. So what I encourage people to do that if it's not a crisis situation where you need the hotline, but if you're thinking, boy, I do need help, then I would reach out. Who in your life do you respect and think highly of their opinions? So it could be if you're a person of faith, it could be your pastor, your minister, right? Or if it could be your doctor or your nurse practitioner. So I would suggest for folks that, I know sometimes making that initial call is hard to say a hotline or seeking out services, but look to your immediate support group, whether it's colleagues at work that you respect, or a supervisor, or somebody at church, or if you're involved with a book club that you feel you have a good relationship with, is reach out to them and say, hey, listen, do you know anybody in the community? I'm kind of struggling with this issue. And so reaching out to somebody you know already may be the first step you can take to getting hooked up with a professional that can help you, support you through these difficult times.
That is very well said.
Right.
And we did not have a conversation that I think is also super important to know, because this is a chat about everyone. The main thing that I hope everyone knows by the end of this, if you've watched it all the way through to this point, that just because you talk about suicide doesn't mean that you're going to put that idea in someone's head. That talking about suicide is a way of prevention, and it is a good way to get someone to open up to you and trust your opinion and your thoughts and your feelings, and let them know that you care. If you ask someone if they're okay, it's not going to make them not okay. So if you ask someone, do you feel like you want to die, or are you planning to take your life? That doesn't mean that you're going to cause them to want to take their life. It means that you may stop them from taking their life.
And it's just add to your point, Rhonda, it's been my experience, and I've worked with kids and youth my whole career, is I think you make a good point. It's the myth out there. If you talk to them about, are you thinking about killing yourself? Are you thinking about suicide? That you're putting this notion in their head. It's been my experience when I've had that conversation with youth, is when you actually ask the question, it's almost a relief to them that they feel like they now have permission to open up to someone. Yes, I am thinking about hurting myself, or yes, I am thinking about killing myself. And this really came home to me. Some of you folks may be aware of, there's this gentleman who, his name is Kevin Hines. And back when, I think he was 19 to 20 years old, he's probably in his 30s now, early 40s. But he attempted suicide by jumping off the Golden Gate Bridge, and he was one of the few people to survive jumping off the Golden Gate Bridge. But in his story, when he tells, and it's a very powerful story, he talks about, if somebody, when I was on the bridge, if somebody would just ask me, are you okay? I would have said something. But he even talked about, there was a tourist nearby, and the person came up to him and asked, can you take our picture? And he took the person's picture. But he said, if she only asked me, are you doing okay? I would have told her. So when we actually do the QPR training, as Nancy was mentioning earlier, the question, persuade, and refer, we actually practice in that hour presentation. How do you ask that question, right? Because it is a difficult question, but I always tell people, when in doubt, ask the question, okay? And if the person thinks you're totally off, they'll say, like, what are you talking about, Joe? I would rather have that situation where, Joe, you're coming way out of left field versus, yes, I am truly thinking about hurting myself or dying by suicide, and say, yes, it's almost like giving them permission to say, yes, I'm in a really dark place right now and I need help. And that's really what's great about QPR. It links that person to the appropriate community resource. And the other thing I think of what it does is it gives that person hope, right? And I think that's a big piece. When we do this this work is giving people hope. Because I think when you're in that dark space, you don't see any hope. And the only thing you think you have the tool in your toolkit is dying by suicide. So I encourage all the people in this presentation today is reach out to those friends, loved ones, and colleagues. The clinicians and the professionals, they do as much as they can, but they don't have that direct contact with everybody, okay? But we do as friends, colleagues, or loved ones, right? We all have friends, we work somewhere, and we have family members. So going through that QPR training and recognizing somebody in distress and then linking them to that appropriate resource and giving them hope, that's how we reduce the numbers in anybody who's thinking about suicide. So those are my words. Thank you.
Yeah, and I just want to piggyback off that a little bit. There's some misconceptions you hear about people who say, oh, well, you know, they talk about suicide, they just want attention. Or the ones that do take their lives, they don't talk about it, they just do it. That's a lot of false information. Even if someone continues to say that that's what they are thinking about doing, that's a red flag, right? That is a cry for help. And we need to take every one of those opportunities to try to get them connected to someone who can help in the now, but also in the long term. We can't just dismiss someone's cry out for help because they've done it before. We have to take it all very seriously because whether it's the 10th time or 20th time, that could be the last time, and that's too much of a price to pay when we can just really lean into that person and check in with them and see what they need and get them connected appropriately.
I totally agree with it's interesting to hear from like an adolescent and childhood perspective, because it's extremely similar in the veteran community where like we're not taught in the military how to ask for help. We're taught to get up and drive on and, be mission ready at all times. And so it's really difficult for, when we get out of the military to transition into that, into that helping culture where we say, hey, I'm feeling bad. I need some help with something. And so when you ask that question, I've actually seen just like a physical like weight being lifted off people's shoulders at times when I said, you got a lot of stuff going on. Has it gotten to a point where you've thought about suicide? Have you thought about killing yourself? And just, you can see that kind of like, because all the messaging that we get in the military is, that's weakness, that's stupid, that's crazy. Whatever you're dealing with is not, justifiable for you to end your life. So even the most, what you might think or what someone else might think might be the most trivial reason for dying by suicide, like, my girlfriend left me, or, I'm having trouble paying my bills. Like, you might think that's a short-term thing, or you might think that's not, a justifiable reason, or someone else might, but that person is in that moment feeling that way. So like you said, it just doesn't help to kind of keep quiet about it. It actually just opens up that trust between you and the client of saying, I'm ready to talk about it. I don't feel scared about it. If you're ready to talk about it, let's work through it. So yeah, I really thought that point was a good one to address.
The one last point on this is if you saw, and this is for the general public, if you saw somebody with a broken leg and they're on crutches coming into a store, you're going to open that door and you're going to help them, right? Because you can see them, they're struggling with their broken leg. It's really, we have to take the same perspective when somebody who might be struggling with suicide, that, we have to open that door to help. And so by going through the QPR training or the training for the clinicians, let's open that door for everyone, right? And get them the help that they need, because the help is out there.
And I think basically basic life-saving skills for mental health. So a lot of us, we keep updated on our CPR and our rescue breathing and, all those basic life-saving skills. It's basically the same thing. All it is giving you that first responders level of ability to be able to have a conversation and treat someone in that kind of acute period of mental health crisis. And then basically saying, okay, I'm going to keep you alive and keep you safe until the next, level of responder gets you.
Yeah, and going back to the military, I said this on Chris Cuomo's show too, but, we've always been trained to suck it up and drive on. That's a phrase that you hear often. In fact, I remember going on a company run. I had the flu. I had a 103-degree temperature. I told my platoon sergeant, he said it was a personal problem, right, to keep on running. So that culture gets ingrained in you, and then you come home and you continue to live like that, although it doesn't serve us here, right? So that's a lot of the issue is veterans and just, I think just people in general, we're often told to, you know, that's just life. Life's tough. Life's hard. All these things. And while that may be true, it doesn't negate the fact that someone's struggling, and what may be hard for one person may be easy for another, and vice versa. You can't discount someone. Somebody's trauma may be getting into a fender bender. That may be the biggest trauma they've ever faced, and it could be just as hard for them as being in a firefight in the middle of the desert. We can't discount their struggle just because it may look different than what we believe it should. And we need to just take everybody seriously and just really, you know, react the same way with love and compassion, but understanding and also resources and truth about, you know, what they're feeling at that time in regards to mental health. So, you know, I think we just got to do a better job in the community is listening to people and actually hearing them and actually, you know, taking what they say and just really, you know, breaking that down and going, wait a minute, whether I believe it's a hardship or not, it is for them, and I need to treat it as such, because I wouldn't want anybody to tell me that an hour firefight in the desert was weak. It wasn't that big a deal, really. It's only an hour out of your life. You're 40 years old. You know, the worst thing I ever heard someone tell a veteran is it was only a 1.5 year deployment. That's all it was. How does it bother you so much? That's ridiculous, right? We don't want to invalidate someone's feelings in that way. So we just need to be mindful and understanding, no matter where someone's coming from.
It's all important stuff. Any level of trauma, whether it's a one-time or a multiple time, whether it's PTSD or complex PTSD, or whether you're diagnosed with that traumatic event or not, is so important to recognize. And everyone deals with trauma differently. Everyone is simulated in their nervous system, all the science stuff I'm not going to go into differently, because your body reacts differently. Our chemistry is different. Our DNA is different. So you're going to react differently. That talk about the differences in trauma, and Joe brought up children, is we need to recognize that military children also have that secondhand trauma. And then there's generational trauma from other things like racism and racial trauma. So you are handing some of the trauma down to your children. So if you're not getting help for yourself, and then you have children, you're creating something called ACEs, which is adverse childhood experiences, which also put your children at risk of feeling the same feelings that you feel or worse. So by getting yourself help for these traumas and pains and these suicidal ideation or feelings of hopelessness, you're helping your children, and you're stopping that chain of event, and your grandchildren. It goes on and on. By helping yourself, you're helping everyone around you. So the fear of not having enough power and strength or being weak is irrelevant when you're looking at your child and saying, if I help myself, I'm helping my kid. So for all the parents listening, by helping yourself, you're helping your child be healthier. And if you want this for your child, you need to have this for yourself.
I guess I just want to thank everyone for being here. What great conversation. I am convinced that when we get off this call, we're all going to want to share this event with the people we work with and make sure that they have a chance to view and see and share from there. So yeah, this has been really nice. Thanks so much.
Thank you all for having us. I just one quick announcement. It's the Service Members, Veterans, and Families Talk. In October, we're having a lady from Cassie Kaywood with Paws for Heroes, and they provide service dogs emotionally, not only for our veterans, but also for a lot of our first responders. So you can kind of get your information on our website. I'm sure that will be very interested. Anything that can help improve mental health and prevent somebody from hurting themselves or others. I think we all agree, we all want to participate in that.
I agree. And Eddie, if you could put that website in the chat, I'll make sure that it's shared out with this video when it's shared out on all platforms. Any of the NAMI Louisville social medias will have these videos, including our YouTube channel.
Okay, I will send you the link. I'll send you the information.
Thank you, sir. And
All
Nancy,
right.
did we mention Homefront for our families of military veterans?
I did not. I think when we met with Jeremy before, he may have heard about it. But one of our 3 education classes is a free 6-week course. It's 2.5 hours, 1 day a week for 6 weeks, led by other family members of veterans who have experienced mental health conditions based on the military experience of their loved one. And it is inclusive in that peer group. So all the individuals that come, we hear a lot of things about, oh, at the VA, there's this that we can attend. So it really brings them together, but gives them that special peer relationship that is the veteran life that their family members have experienced. So I can certainly share information about that course with you guys as well, so that we can make sure that when we do offer it, which is a couple times a year, that your groups are aware of it and can share it out with their families and loved ones.
Mm-hmm. Perfect, thank you. Anyone else have one last closing statement to say before we close out? Well, it looks like we've had a productive discussion and a lot of information. If you've watched this far, you will catch us on all social medias, and we look forward to having discussions and sharing all of these resources that were added in the chat with you in the comment sections and in descriptions of this video. Thank you everyone for coming. It is very important that you were here, and you are very appreciated. Thank you.